Dr. Spencer, what screening test do you recommend that a C&P examiner use?
A nice portable test would be the MoCA. The MoCA assesses a lot of the abilities that are sometimes impaired with traumatic brain injuries, such as executive function and processing speed. And those are abilities that aren't assessed in the mini-mental, another popular screening instrument. With any screening, there's a good bit of uncertainty. And with a measure like the MoCA, which assesses a lot of the abilities that are important in traumatic brain injury, you just sort of narrow the uncertainty a bit. There's always some, but you narrow the uncertainty a bit, and that's a good advantage of the MoCA.
Dr. Spencer, can you show me an example of the MoCA test?
Sure. MoCA is very portable, which is a good advantage of the MoCA. The MoCA contains tests that tap a number of abilities. There are tests of executive function, which is sort of allocating your attention to a task involving monitoring your performance and generating novel responses. There are also visual spatial tasks, tasks of naming, tasks of attention, simple language tests, and a little bit of memory. And with that, you can get a good sketch of somebody's cognitive strengths and weaknesses. And it's useful for a screening because it taps so many abilities that you can see in some cases if there are cognitive problems that should be explored further by a neuropsychologist.
If the veteran clearly complains of cognitive deficits, and I have already decided that I will need to refer him or her for neuropsychological testing, is it still useful for me to perform a screening exam for cognitive deficits?
Mm-hmm. If a veteran complains of cognitive problems, yet you're not sure if you want to give a screening evaluation, the recommendation would be that you still screen the veteran. That screening information can be used when you refer for full testing as information to give a rough idea of what the strengths and weaknesses of the veteran are. In a mini-mental, it's less the case. The mini-mental state exam, being as easy as it is probably not going to have much variation between veterans on their scores. But the MoCA, being an improvement for this population, will give the person at the next step some information that they would need in order to make a good assessment. Additionally, it's always good to have objective information on hand when discussing the strengths and weaknesses of a patient. If the patient performs poorly on the screening exam, then you have some information to sort of buttress what you're saying about cognitive problems. And if they perform well, and acknowledging that there will be some false negatives, but if they perform well on examination, then it kind of gives a heads up to the next stage that maybe these deficits, if they exist, are very subtle, and that the tests used to assess them need to be quite difficult and taxing in order to tease apart any subtle problems that might exist.
So you mentioned false negatives. What would a false positive be?
A false positive would be somebody that performs poorly on an initial evaluation or any evaluation, but that actually doesn't have the condition that you're exploring. So in this case, it would be someone that does not have a mild traumatic brain injury, or at least does not have lingering pure cognitive effects from a mild traumatic brain injury, but that appears to. And one of the ways would be if somebody has a premorbid history of difficulties in the areas that we assess. So for instance, attention problems, learning disabilities, things of that nature. Also, a lot of cognitive abilities have individual variation, and we do a fair job at sort of estimating what the premorbid abilities would be, but individual variation, sometimes people are just perform poorly on some tests, and that's a small amount of error that we have to be willing to live with. Another thing that can cause false positives are things like poor sleep, chronic pain, and something that will happen occasionally is disinterest in the evaluation. If someone is going through it as maybe feeling coerced, maybe feeling like this is not really going to be informative, You might find poor performance in someone that really doesn't have deficits, the way that the scores are portraying on the tests. And that's why it's important to consider whether effort testing is used. A lot of times in a screening evaluation, you can't test for effort. But neuropsychologists are typically very good at including test of effort, plenty of test of effort, when they give a full evaluation. So if low effort is suspected, that can be a false positive that can easily be teased out, or in many cases can be teased out in a full evaluation.
Part 8, Psychiatric Manifestations. Observe the veteran for any psychiatric manifestations, including neurobehavioral effects. If a mental disorder is suggested, a mental disorder or PTSD examination is required. Part 9, Vision and Hearing. Perform a screening exam for vision and hearing. If any abnormalities are found, or if there are symptoms or complaints of an eye or ear impairment, request an eye or audio exam by a specialist. Part 10, Skin. Examine the skin and describe any areas of skin breakdown due to neurologic problems. Part 11, Endocrine dysfunction. If endocrine dysfunction is identified or suspected, select and follow additional appropriate examination protocol for the type of endocrine disorder identified. Part 12, Autonomic dysfunction. Report any symptoms of autonomic dysfunction, such as heat intolerance, excessive or decreased sweating. Part 13, Other. Describe any other abnormal physical findings. Part 14, Assessment of cognitive impairment and other residuals of TBI not otherwise classified. This area is composed of 10 topic areas or facets. For each of the 10 topic areas, there is a question and a choice of multiple choice answers about the veteran's cognitive functions and other residuals of TBI. It is essential to complete this area thoroughly. The topics are as follows: memory, attention, concentration, and executive functions, judgment, social interaction, orientation, motor activity, visual spatial orientation, subjective symptoms, referring to the subjective symptoms previously described on the history questions labeled A through Z. The area of subjective symptoms is clarified as meaning that instrumental activities of daily living refer to activities other than self-care that are needed for independent living, such as meal preparation, housework or other chores, shopping, traveling, laundry, being responsible for one's own medications, and using a telephone. These activities are distinguished from activities of daily living, which refer to basic self-care and include showering, dressing, eating, getting in and out of bed or chair, and using the toilet. Neurobehavioral effects, communication, and consciousness. Any problems with memory, attention, concentration?
Just mild.
Mild memory loss, such as having difficulty recalling conversations, things like that?
Yes.
Okay. Okay. Visual spatial orientation. Multiple choice responses are provided on the TBI worksheet and in the Capri template. Select one of these multiple choice answers to respond to each of these 10 topics. The clinician must report the title of the item and then report the answer using the descriptions after the letters A through E that best documents the veteran's level of functioning, as in judgment normal. Assessing each element of cognitive or physical impairment is a CPEP quality indicator.
How do we know when we need to refer a veteran for neuropsychologic testing for the purposes of a compensation and pension TBI exam?
The question of when to refer a veteran for neuropsychological testing in the context of a compensation and pension evaluation involves several factors. Now, good background information is to know that neuropsychological testing can be very informative in giving a detailed explanation or a detailed description of someone's cognitive strengths and weaknesses, as well as capturing their emotional functioning and exploring the amount of effort that they're putting forth in the evaluation. If someone performs poorly on a screening evaluation, that's enough reason to send them for a full evaluation. But there's caution that should be used. Someone can perform well on a screening evaluation, especially something like the mini-mental, which is typically very easy, particularly in this population. In those cases, you'd call them a false negative. You know, you risk a false negative. Someone may have problems, but they appear as though the diagnosis would be negative, that they're fine. In those cases, you'd want to look at the characteristics of the injury, and you'd want to look at what the patient says, what the veteran says. Perhaps they say they have problems with their memory. They have problems with concentration. They have problems with organization, maybe even processing speed, thinking slowly. In those cases, it's very informative for full neuropsychological testing, especially since over 95% of veterans will make a full cognitive recovery from a mild traumatic brain injury. And neuropsychological testing can be very informative in those cases. So I would say a good clinical judgment, a good history, injury characteristics, and screening tests are the main factors that should be used.
Once I order neuropsych testing, what can I expect to learn from the results of the neuropsych testing?
Neuropsych testing is excellent at providing objective information. Typically, the scores are compared to people matched on demographics, so you can tell where the person falls relative to their peers. And that can be helpful for learning a veteran's strengths and weaknesses cognitively, which is good for treatment planning and also tracking improvement. You know, it's good news when you can tell a patient or you can tell a veteran that they're back to where they should be, you know, that their cognitive symptoms have improved. And you typically expect a lot of improvement in the first 6 months or so. Also, neuropsychological testing almost invariably includes assessments of emotional functioning. So you can form very good hypotheses about the etiology of their problems. You know, if it's a patient comes in and they're extremely depressed and they're anxious and they're not sleeping and they have chronic pain and their performance is just a little bit below what the performance of their peers would be, and you can make a reasonable interpolation that this is probably a decrease in functioning because of the emotional problems and the pain and the lack of sleep. So it can help diagnostically, I guess is a way of summarizing that.
So how long does it take you to do a neuropsych exam?
Here in the clinic, every veteran that comes in for a traumatic brain injury evaluation gets a 45-minute battery. And I give a screening battery of tests that include tests of concentration, tests of working memory, so holding information and manipulating it, tests of verbal memory, tests of visual memory, tests of organization, as well as emotional functioning and sleep. If they perform poorly, or there are significant cognitive complaints, or if the nature of their injury suggests that more testing would be needed, then they come back and see me for an evaluation that lasts between 3 and 5 hours. And the individual cognitive functions are tested in more depth. So the test of memory are more comprehensive. The test of attention are a lot more difficult. And the test of emotional functioning are much more comprehensive. And with that, you can get a clearer picture of which functions, cognitive abilities, are spared and which functions are still causing problems.
Okay, so this is a 25-year-old with a history of several blast injuries. Mm-hmm. Did you complete his neuropsych testing?
I did. It was essentially a normal exam.
Okay.
He really did fine. I can get more specific. His verbal memory was really good. His verbal memory was actually well above average. Mm-hmm. His visual memory was average, and there were no problems with attention or processing speed. Mm-hmm. And he was pretty well organized in the test. So essentially, cognitively, I'd say it was a normal exam.
He didn't seem depressed when I spoke to him and interviewed him. Was there any sign of depression on your screening?
He didn't seem depressed to me at all. Okay. And when I gave him checklists of depression and anxiety, he didn't report any depression, but maybe some mild anxiety. He was below threshold, but there was a little bit of anxiety. And I mean, incidentally, his substance abuse, his alcohol abuse was fine. His screening was completely negative.
No evidence of substance abuse or alcohol abuse, but a little anxiety. Okay.
A little anxiety, but it really didn't affect his performance at all.
Okay. All right, that's helpful.
Yeah.
Thank you. So thank you for coming in today and participating in everything. You did very well. We've completed your evaluation, and we will prepare a report to send back to the regional office on your behalf. Did you have any questions before we conclude?
No. Thank you very much.
Okay, thank you very much. Goodbye.
Bye-bye. Thank you.
Diagnostic and clinical tests. Include results from all diagnostic and clinical tests ordered and conducted for the examination. Including the results of all conducted diagnostic and clinical tests is a CPEP quality indicator. Diagnosis. List each diagnosis, stating the diagnoses precisely, and if you are unable to provide a precise diagnosis, providing justification for the lack of diagnosis, are core CPEP quality indicators. Each diagnosis must provide a comment on its association with a claimed TBI. For example, for the veteran's claimed condition of headaches, the diagnosis is TBI-associated tension headache. This condition is at least as likely as not caused by or a result of the veteran's claimed TBI, as the onset of the condition occurred immediately following the blast injury. Capacity to manage financial affairs. You must include the capacity to manage financial affairs in your exam report. Mental competency for VA benefits purposes refers only to the veteran's ability to manage his or her VA benefit payments. In order to assist raters in making a legal determination as to competency, the examiner should address the following in his or her exam report. What is the impact of injury or disease on the veteran's ability to manage his or her financial affairs, including consideration of such things as knowing the amount of his or her VA benefit payments, knowing the amounts and types of monthly bills, and handling the payments of bills prudently? Does the veteran handle money and pay the bills by him or herself? Based on your examination, do you believe that the veteran is capable of managing his or her financial affairs? Provide examples to support your conclusion. If you believe a social work consult is needed, obtain this consult and include a summary of the results in your exam report. Addressing the veteran's ability to manage VA benefits is a CPEP quality indicator. Remarks and opinions. This is where you should address and provide answers to all opinions requested as part of the general remarks section of the exam request. Be sure to use appropriate medical legal language for your answer and rationale. Providing the requested medical opinions using proper medical legal language is a core quality indicator. When a mental disorder is present, be sure to communicate with the mental health examiner so that he or she states, to the extent possible, which emotional or behavioral signs and symptoms are part of the comorbid mental disorder which represents residuals of TBI. If it is impossible to make such a determination without speculation, the mental health examiner should so state. Discussing the veteran's mental disorders, if present, and distinguishing symptoms from TBI is a CPEP quality indicator. It is your responsibility to coordinate with the mental health examiner to make sure that this opinion is included with every TBI exam report that includes a mental health exam. In order to meet this quality indicator, the examiner must coordinate his or her response with the mental health provider. This judgment may be deferred to a mental health provider, but the general examiner must reference the mental health report in his or her TBI exam report.
To know if the cognitive deficits are the result of a traumatic brain injury, again, it's useful to use the full neuropsychological testing data and all of the nuances that are tested therein. However, other factors that you'd want to consider at the level of the clinic or in a full evaluation is their pre-morbid history of problems. And there's a lot of individual variation with abilities, and a lot of veterans have histories of learning disabilities or attention deficits, and it's possible that the problems were pre-existing. Also, if subsequent to the injury, if there's a waxing and waning of symptoms, or if symptoms were not present for a while and then appeared long after the injury, then you would suspect that maybe the problems are not the result of the injury and that other etiologies should be explored, such as depression or anxiety or some sort of a traumatic reaction.
Okay, one other question I'm frequently asked, or one other opinion I'm frequently asked to provide is the veteran's memory loss in that case or cognitive impairment attributable to his traumatic brain injury?
And that can be a question that can involve a lot of factors. If you're asking if somebody's memory problems are attributable to the traumatic brain injury, you'd want to consider historical factors in that case. You'd want to find out about their school performance, and if there are any school records available or testing before the injury, that can be very informative. If you're comparing pre and post, and you can make a reasonable inference in some cases of whether the injury caused the memory problems. The other thing that you'd want to consider is, again, are there emotional problems that have resulted from the injury, and if so, what is the degree to which the emotional problems have been there? In a case, for instance, if there are mild or very few emotional problems, and the person was performing at a very high level, and they present for testing and they perform very poorly, then a reasonable inference can be made that the event had some causative factor. Now, one thing that I find informative, though, is if there is testing subsequent to the injury and their performance was okay, it was right at expectation, yet they're performing poorly now, that's not typical of traumatic brain injury. Usually there's a consistent performance increase, that there's a recovery. And if performance is low, then other factors should be explored.
So if the symptoms seem to wax and wane, that's not typical for traumatic brain injury?
No, waxing and waning of symptoms is not typical of traumatic brain injury. Traumatic brain injury, you'd see a steady increase in performance and then a leveling off after a while. And in over 95% of cases, there's full cognitive recovery in mild traumatic brain injury.
Unfortunately for the diagnostician, there is no one symptom that is unique to or diagnostic of mild TBI or post-concussive syndrome. Most of these symptoms do occur in normal, healthy individuals. All symptoms overlap with one another in conditions such as PTSD, depression, anxiety, chronic pain, somatoform disorder, other chronic health conditions. So the question becomes, is this history, examination, neuropsychological test results, and group of symptoms consistent with TBI, or is it more likely something else? The following list is by no means an authoritative reference for distinguishing mild TBI from other conditions. However, it can be used as a guide to assist the clinician in making this distinction. Typical symptoms of TBI include impaired concentration, headaches, memory problems, irritability, apathy, poor insight. PTSD symptoms frequently include persistent re-experiencing of the accident, numbed general responsiveness, nightmares, and symptoms often worsen over time. Symptoms of depression may include psychomotor retardation, early morning awakening, changes in appetite or weight, and suicidal ideation. Symptoms of chronic pain may include sleep deprivation, irritability, a somatic focus, avoidance of activities, and weight gain. Sleep deprivation may cause generalized cognitive symptoms, headaches, decreased attention and memory. Malingering will show some specific patterns seen on neuropsychological testing. Frequently, true TBI patients don't have insight into their own symptoms. They have apathy, poor initiation, They don't always complain about their symptoms. It's been my observation that chronic pain and depressed patients report more TBI symptoms than TBI patients. Hence the importance of asking the patient the 26 symptom inventory to try and elicit these symptoms from the patient. Our first case is a 24-year-old man who was evaluated for TBI and campanipanival. He reported a history of motor vehicle accident during his deployment. He was the restrained driver of a truck that was hit by an improvised explosive device. He was wearing a helmet. He has no memory of the event or of being evacuated. He was evacuated from the scene and he was taken to a local field hospital. He reports residual physical, cognitive, and behavioral symptoms. Physically, the patient recovered and actually did return to service and received an honorable discharge. His symptom inventory was significant for him reporting ongoing headaches, at the worst 9 out of 10 in severity, and more routinely 7 out of 10 in severity, that had begun shortly after the event and continued through the subsequent months until his evaluation. He also reported difficulty with memory, distractibility, poor attention span, poor organization and decision making. He needed help with managing finances. He also reported behavioral symptoms of rage, reactions, and apathy, and poor initiation. He had difficulty with social interactions and was reporting that he avoided public places because of this. His physical examination was essentially normal except for some mild increased tone on the right upper and lower extremity. He had no strength deficits. Cranial nerves were normal. He underwent neuropsychological screening testing.
And the screening did uncover some problems. He had some difficulties with attention and concentration, as well as memory that would be considered in the low average range. His processing speed was very slow, so overall it was suggestive of continuing cognitive problems.
Our summary is that the veteran had a mild TBI with ongoing physical, cognitive, and emotional impairments, most likely caused by or a result of mild TBI. Our diagnosis was mild TBI with residuals of migraine headaches, cognitive impairment problems of difficulty with memory, distractibility, poor attention span, organization and decision-making, and behavioral problems of rage reactions, apathy, and poor initiation. Our next case presentation is of a 21-year-old male who was in the Marine Corps for 3.5 years. He was most recently deployed from August through November of 2006. He reports at the end of November an incident where he was the passenger in a Humvee that was hit by an improvised explosive device on the driver's side. He was with 2 other soldiers at the time. He reports that all 3 of them were knocked out for less than 1 minute. They recovered. There was some mild confusion at the time, but they acted very quickly and subsequently participated in a firefight which lasted about 30 minutes. He was wearing a helmet and had no significant residual deficits after that time. He was in a second explosion about 1 month later where he was on foot on ground patrol and a grenade exploded less than 5 feet away from him. He was blown backwards. He had a loss of consciousness for approximately 2 minutes. He was evacuated from theater and treated immediately for injuries to his hand, hip, and forearm. He was taken to surgery immediately after that, and he does not recall any subsequent events until waking up after his surgery. He reported ongoing symptoms including almost daily headaches ranging from 7 to 9 in severity. He reported very severe hearing difficulty, very severe difficulty in falling asleep and staying asleep. He also reported having nightmares every night. He had reported very severe irritability, and being easily annoyed. His current medications included Seroquel, which he felt was helping. Another thing that the patient reported was that his symptoms were getting worse since he had returned home. On physical examination, he was alert and cooperative. His neurologic examination was essentially normal. His physical examination was consistent with his injuries to his hand, forearm, and hip. He underwent neuropsychological testing.
And during this veteran's neuropsychological testing, he reported mild depression and anxiety. But although mild, they were in the clinically significant range. Cognitively, however, he performed either at the average level or above on most measures. He was above average on tests of attention, processing speed, and verbal memory. His visual memory was a little bit on the lower side of the average range. And overall, his cognitive functioning seemed to be in the normal range.
Our impression is that the veteran suffered a mild traumatic brain injury during deployment, and that his baseline headaches, having started shortly after his surgery, were related to the mild TBI. However, the patient also had other symptoms that were most likely not related to his TBI, and these included the worsening of his headaches, his sleep disturbance, and nightmares, which were more consistent with post-traumatic stress disorder or post-traumatic stress symptoms. Our next case is a 25-year-old male who returned home from deployment about 6 months prior to our evaluation. The history is that he was entering a building and was shot in the leg by a sniper. The bullet entered his leg, struck his femoral artery, and severed his sciatic nerve. He fell to the ground. He's not sure if he struck his head or not. He had severe blood loss and did lose consciousness at the scene. He was immediately tended to, evacuated, and taken to surgery. His artery was repaired, but his sciatic nerve could not be preserved. This resulted in complete loss of sensation below the knee and complete loss of ankle strength. His residual symptoms included severe pain of the leg, including mechanical and neuropathic pain. He was ambulating with a cane. His symptom inventory included irritability, short fuse, difficulty with memory and concentration. In addition, I will also report that his PTSD screening questions were negative. His medications included both anticonvulsants and narcotics for pain control. He had neuropsychological testing as part of our evaluation.
In our neuropsychological screening evaluation, he performed average or above on all measures. And keeping in mind, he had cognitive complaints, but compared to his peers, his performance was completely fine.
So our impression is that while the patient did have a loss of consciousness at the scene, it is more likely than not that the loss of consciousness was related to blood loss and that he did not have evidence of TBI or residual symptoms that could be attributed to a TBI. We felt that his ongoing symptoms were most likely related to pain, sleep deprivation, and side effects from his medications. Our next case is a 25-year-old male who was deployed from January of 2004 to February of 2005. He reports multiple small blast exposures, one serious involving an improvised explosive device that exploded within 10 feet of him. He had minor skin burns and shrapnel injuries and also fell to the ground and had a loss of consciousness of less than 1 minute. He had a few minutes of subsequent confusion, but no post-traumatic amnesia. His symptom inventory included headaches that incidentally began after his return home, occurred approximately monthly, and were mild in severity. He also reported mild anxiety and depression and moderate irritability. His PTSD screening questionnaire was essentially negative. His physical examination was essentially normal, including his neurologic examination. He did undergo neuropsychological screening.
And in the neuropsychological screening, his memory was in the average range compared to his peers. His attention, however, was in the superior range, and his processing speed was also above average. So both of those things are encouraging, and there's no suggestion from this data that there are lingering cognitive problems.
Diagnosis: mild TBI without residual symptoms. Clinicians should note that headaches are not expected to be related to TBI if they began months after the injury. Also, emotional and behavioral symptoms due to TBI would typically be accompanied by some cognitive deficits. Let's review what we've covered in this program on the C&P exam for traumatic brain injury. We provided a definition of TBI, which is based on the VA training letter. We talked about reviewing the veteran's C-file and medical history before the veteran arrives in preparation for doing the exam. Pay special attention to whether or not a diagnosis of TBI by an approved specialist is included in the veteran's medical records. We want to emphasize that TBI is not the rateable entity. TBI is a historical diagnosis, and the rateable entity is the diagnosed residual effects. The residual disabilities need to be diagnosed in relation to TBI as the causal factor. We covered how to use the worksheet or template to take the veteran's medical history and how the examiner must specifically ask and document the answer to each of the 26 medical history questions labeled A through Z on the exam worksheet or template. We walked you through the physical exam and concentrated on each of the 14 parts, including special emphasis on Part 14, assessment of cognitive impairment and other residuals of TBI not otherwise classified. Part 14 is comprised of the 10 multiple-choice questions that are particularly important to the rating specialists who make the disability determinations. We covered what to do after the exam is finished and what to include in your written report, including the findings from all additional clinical tests ordered and your judgment of the veteran's capacity to handle financial affairs. Throughout the process, we highlighted the CPEP quality indicators, those aspects of the exam process and the resulting report that should be given extra attention by the examiner to ensure completeness. Before we finish this program, we'd like to review 2 issues regarding the C&P TBI exam, which can potentially be confusing for examiners. First, regarding the issue of who is allowed to make an official TBI diagnosis and what to do if there is and is not an existing diagnosis of TBI in the medical records. The medical specialists who are approved to make the diagnosis of TBI are physiatrists or physical medicine and rehabilitation specialists, neurologists, neurosurgeons, and psychiatrists. If there is a TBI diagnosis by an approved specialist documented in the veteran's medical records, then make note of this in your written report. If the veteran has not been previously diagnosed with TBI by an approved medical specialist, then the general C&P clinician must send the veteran for a consultation to one of the approved specialists for diagnosis. The general C&P clinician may not diagnose TBI without previous documentation or consultation from a specialist. The general C&P clinician may still complete the C&P TBI exam but should hold the report until information from the specialist's consult has been received. Then the diagnosis provided by the specialist can be added to the final report. Second, let's revisit the process of whether or not to order neuropsychological testing. The general C&P examiner should use a screening tool to check for cognitive impairment unless there is existing documentation of a recent neuropsychological exam in the veteran's medical records. The MOCA is one example of a screening instrument to use. Additional neuropsychological testing should be obtained if the screening tool indicates any cognitive impairment, the veteran reports any cognitive impairment during the medical history, or the veteran causes the C&P examiner to suspect that there may be cognitive impairment. Remember to include the results of any neuropsychological testing in the exam report. Finally, please remember that a C&P exam is a disability exam. It is not a treatment exam. The sole purpose of a C&P TBI exam is to provide evidence to the VBA so they can determine disability compensation. We hope that this program has helped you to be prepared for your role as a compensation and pension examiner able to do C&P TBI exams for the Department of Veterans Affairs.